I'm Mohammed Shazli. I'm a junior faculty at Faculty of Medicine working in the hemato-oncology. We are establishing our scientific oncology society, which is basically there to provide for 4 goals. First of all, we will be working on scientific research in the field of oncology. Second of all, we'll be providing physician education and physician support for oncologists. Third, we will be providing, one of our aims is to provide patient education and patient support. And last and not least will be public awareness about cancer. So these are the 4 main pillars of the SOS, and we hope to establish them in the forthcoming period. Getting to present Professor Heribert Jürgens. Professor Jürgens had a very fruitful career. He was educated in the Faculty of Medicine of Düsseldorf and Glasgow. He had his started his professorship in the year 1982, the year that I was born. So he was a professor since then at the University of Düsseldorf. He was awarded a lot of posts and as an extraordinary professor in 1989. He was the director in 91. He was the director of the clinic and the polyclinic of pediatric hematology oncology at the University of Munster. A lot of awards was given to him. Last of them was the Federal Cross of Merit in the first class. Also, he is, of course, a member and a chairman of a lot of respected societies. The last of them was the Society for Paediatric Oncology and Hematology in 2006. He was appointed as Vice Dean, then as Dean of the Medical Faculty of Munster, and we are honored to have him here today to talk us about the multimodality treatment of Ewing's sarcoma. Please, Professor Jürgens, proceed.
Thank you very much for this very, very kind introduction. I'm honored to be here and to be invited, and I hope after your introduction I am able to meet your expectations. I cannot think of any conflicts of interest I have to declare with my lecture. Nevertheless, I have to mention this. We are talking about Ewing's sarcoma today. Ewing's sarcoma, as you will know, is the 2nd commonest bone tumor in the adolescent age. And what is important to know is that Ewing's sarcoma this year has its 100th birthday. Ewing's sarcoma was first described by James Ewing. James Ewing, who lived from 1866 to 1943, was a very famous cancer specialist. He was famous for his textbook on neoplastic diseases, which was first published in 1919 and had 4 editions. The latest edition was 1940. And this book was supposed to be the Bible of oncology at the time. He first described what he called a diffuse endothelioma of bone in 1921, as I said, 100 years ago. The first report where this was called Ewing's sarcoma was published 1927 by someone from Canada. In 1931, he was on the front page of the Time magazine for Cancer Man of the year. So he was quite famous, and his contributions to the field of oncology are enormous and very, very important. Now about Ewing sarcoma. Not all of you are pediatric oncologists, but also as a medical oncologist, you see Ewing sarcoma because it's a disease of the second and third decade with a median age of presentation around 14 years of age. It has a male predominance of 60 to 40%. This is what you are familiar with in osteosarcoma, but osteosarcoma is the more common, the bigger brother of Ewing sarcoma, is a tumor of the bone metaphysis, and Ewing sarcoma is more a tumor of the diaphysis of the bone, and it can appear in long bones as well as a trunk. So the pelvis is a very common presentation, with approximately between 20 and 30% of all Ewing sarcomas present with a pelvic primary location, but it can be in the diaphysis of long bones, it can be in ribs, it can be in the chest, and wherever. It's characterized on histology by a pattern of small blue round cells. It's glycogen rich, it's PAS positive, that's why it's PAS positive. Later a marker was described, CD99, and approximately 1/3 of Ewing sarcomas may express neuronal markers, but with or without neuronal markers, it's the same disease with the same presentation and the same prognosis. Later on, Ewing sarcoma became a paradigm of molecular characterization. It's described by a specific translocation, chromosome 1122. This results in a transcriptome, which is supposed to be a transcription factor and is supposed to be involved in the malignant process. This later became then a model. Later after this, more and more of such chromosome transcript arrangement characterized tumors were described, and Ewing sarcoma still is the leader of this list, and quite often the chromosome 22 is involved in those translocations. When Ewing first described Ewing sarcoma, he described the prognosis as disastrous. At the time, there was a less than 10% survival of Ewing sarcoma, despite immediate local therapy. There was no chemotherapy available at the time, and he already recognized that Ewing sarcoma is radiosensitive. This is very different from osteosarcoma, which is considered to be radioresistant. So nevertheless, despite early surgery, whenever feasible, or early radiation, less than 10% of patients survived. And it was not until the 60s, 70s, where another treatment modality became available. You see the first steps into the world of chemotherapy of Ewing sarcoma, single drug activity. Look at the low number of patients published in this series, between 5 and 10 patients. There was a response rate, but this is single drug activity and did not at the time result in any improvement of prognosis. The heroes of describing combined modality Ewing sarcoma treatment and improving the prognosis are both Gerald Rosen from New York Memorial Sloan Kettering Cancer Center, the institution where James Ewing had been working, and Norman Jaffe, who was in Boston at the time and later moved down to Houston, MD Anderson. The success road that are Gerald Grosen and Norman Jaffe started, were combining chemotherapy agents at the time as a sequential regimen. Later on, they moved into a more intensive combined agents chemotherapy regimen. And from the 70s until now, this was the era of describing the importance, the impact of chemotherapy on prognosis in Ewing sarcoma, and moving to more and more intense regimens. This is the evolution of chemotherapy intensity in our own group, the European group. The GESR-81 study is very similar to the Rosen protocol, and then more and more agents were introduced at more and more higher doses. And just look at the evolution of chemotherapy treatment strategies in the European group. The first study recruited in 4 years 184 patients. The second study, 490 patients, with more and more institutions recruiting patients. The third study recruited 875 patients, and the next study then recruited over 3,000 patients from the whole of Europe and other countries in the world. As a result of combination chemotherapy, this was the first time that Ewing sarcoma became curable. Not all patients could be cured. You see the plateau, which was in the beginning below than 10%, has now reached a level between 60 and 70, and nowadays with the most recent studies above 80%. And more groups have adopted such strategies and are competing for the best chemotherapy regimen. Let's look at some lessons learned from these groups and from the result of various attempts. This is an important lesson learned from the Children's Oncology Group in the United States. They showed very nicely that the addition of ifosfamide, of the combination of ifosfamide and etoposide to standard 4-drug chemotherapy, resulted in an improvement of prognosis, but as you see here, only in non-metastatic disease. In the high-risk metastatic disease I mean at initial presentation, there was no improvement of further intensification of chemotherapy. And another lesson learned again by the Children's Oncology Group was when it was seen that chemotherapy intensity is so important in treatment success and cure in Ewing sarcoma, treatment intensity you can give either by higher doses every 3 weeks, as is usually chemotherapy is administered after recovery of blood counts, or you give standard doses at shorter intervals at for instance 2-week intervals. And again, it was learned from the Children's Oncology Group that interval compressed, as they called it, chemotherapy regimens had a somewhat better prognosis in Ewing sarcoma, but again, this was mainly in standard risk patients and not in high risk patients and not in patients with metastasis at diagnosis. In our own group, we again try to learn from several chemotherapy modifications. We started with a very, very intense induction regimen with incristin, ifosfamide, doxorubicin, and etoposide, and then randomized. This was before local therapy. This 6 courses every 3 weeks, meaning this results in 18 weeks upfront chemotherapy, was then followed by local therapy. Local therapy we will look at later. And then we randomized for a high-dose maintenance chemotherapy compared to a standard dose chemotherapy with cyclophosphamide instead of ifosfamide. The result of this is that after an intense induction and after local therapy, you do not need a very, very intense maintenance chemotherapy. You can continue with standard dose chemotherapy by replacing cyclophosphamide for ifosfamide. The second randomization was in high-risk patients, and there the randomization, the question was, do patients after induction chemotherapy benefit from high-dose chemotherapy with autologous stem cell transplantation as compared to the standard maintenance chemotherapy? When we looked at this at high-risk patients, this patient with large tumors and poor response to chemotherapy, this is the busulfan-melphalan autologous high-dose chemotherapy followed by autologous stem cell rescue compared to the conventional maintenance chemotherapy. Yes, there was a benefit of approximately 15% in such high-risk patients. When we looked at when we asked the same question in high-risk patients who, in addition to a high-risk local presentation, had lung metastasis, there the comparison was the standard chemotherapy maintenance with whole lung irradiation. This was compared to busulfan-melphalan high-dose chemotherapy without whole lung irradiation. And here we see when you compare standard chemotherapy with whole lung irradiation to standard chemotherapy with the addition of chemotherapy, of high-dose chemotherapy and autologous stem cell transplantation, there is no longer a significant difference. So in patients with lung metastasis, the addition of whole lung irradiation is of same benefit as compared to autologous bone marrow transplantation after high-dose chemotherapy. So in summary, the standard in treatment of Ewing sarcoma is you need systemic chemotherapy. You start with chemotherapy followed by local therapy for approximately 10 months to 1 year. And the chemotherapy, the conventional chemotherapy consists of anthracyclines, of alkylating agents, of Wimper alkalides, of topoisomerase inhibitors. And of course, you need local therapy. This is usually nowadays followed by 9 to 18 weeks of induction chemotherapy with surgery, radiotherapy, and or the combination of surgery and radiotherapy. Now we look at risk factors. Do all patients have the same diagnosis, or are there particular groups of patients that have a better or poorer prognosis? And there are 4 categories of risk factors in Ewing sarcoma and treatment of Ewing sarcoma you have to be aware of. One important factor is this a patient with local disease at the base of staging investigations, or are there metastases present at diagnosis? The next is we will focus on histological response. We will look at tumor volume, and we look at the impact of local treatment, local therapy. Metastasis at diagnosis. Depending where you are and how long a patient takes until he is seen at a center, approximately 75% of patients present with localized disease, and 25% have visible metastasis at the time of diagnosis. And in Ewing sarcoma, different from osteosarcoma, this can be lung metastasis, this can be bone marrow metastasis, or this can be combined modality, lung and bone multisystem disease. In osteosarcoma, as you might be aware of, this is the same 75% localized disease and 25% metastasis at diagnosis, but they are nearly all patients have lung metastasis only. So the presence of metastasis at diagnosis has a very, very strong impact on prognosis. As you can imagine, localized disease, the prognosis is much better compared to patients with metastasis at diagnosis. And in patients with metastasis at diagnosis, patients with lung metastasis have a better prognosis to patients with either bone marrow metastasis or multi-system disease. Next, you know that we start treatment in Ewing sarcoma with chemotherapy and then focus and move on to local therapy. In patients that go on to surgery for local therapy, you have the possibility to examine the surgical specimen for the grade of viable tumor at the time of surgery following induction chemotherapy. When you look at the impact of the tumor destruction from chemotherapy and the response to chemotherapy, again, there is a strong impact on prognosis. The cutoff point conventionally is whether there are less or more 10% of viable tumor cells in the surgical specimen. And the prognosis of patients with less than viable cells in the surgical specimen is approximately around 70%. And the prognosis of patients with more than 10% viable tumor is less than 50% long-term disease-free survival. And when we look at our series of chemotherapy regimens, with increasing chemotherapy intensity, the proportion of patients with good response to chemotherapy has increased from just above 60% to now approximately 80% nowadays. The next impact is, does the tumor burden measured as volume of the primary tumor have an impact of the prognosis? This is this long-term disease-free survival for patients with a tumor volume less than 200 milliliter, which is an orange or an apple or however you want to call it. And you see that the prognosis is around 75 to 80%. You see the relapses occur, we will look at this, we will discuss this later, quite early, and there's a plateau later on. And you see in patients with these small tumors, there is no significant difference with respect to the modality of local therapy, surgery, the combination of surgery and radiation, or definite radiotherapy. When you look at the same for patients with larger tumors, meaning larger than 200 ml as cutoff volume, you see there is the prognosis is well below 50%, and there's then a significant difference between with respect to the modality of local therapy. Patients with radiotherapy in these patients with large primary tumors, their prognosis is poorer compared to either surgery alone or the combination of surgery and radiotherapy. So this leads us to discussing the impact of local treatment in Ewing sarcoma. This is the overall analysis. Surgery alone and surgery followed by radiation, there is no significant difference. There's a small difference, but no significant difference. And patients with sole radiation and radiation alone, their prognosis, long-term prognosis, is lower than 50%. So why is this? If you look at the total group and look at the type of relapse, this is when you look at surgery compared to surgery and radiation alone, the patients, the long-term remission is 50% with radiation alone and is around 70% with surgery and combined modality surgery and radiation. And why is this? Because the proportion of patients with local recurrence or combined local and systemic recurrence is lower in the surgery group and the combined modality group with 4%, 3%, 2%, 1%, compared to the radiation alone group with a proportion of 13% local recurrence and 15% combined local and systemic recurrence. So there's an impact of your choice of local therapy in patients with Jürgens sarcoma. In our European group, the various countries and national groups, England, France, Germany, Scandinavia, etc., they had a different approach to their preferred choice of local therapy. I divided this, not telling you any names, in Group A and Group B. Group A, the preferred choice was either surgery or radiation alone, and only a small percentage of patients had combined modality treatment. Group B preferred combined modality in over 60% and had only small proportions of patients with surgery alone and radiation alone. And if you look at the global outcome, so Group A, who has had a higher proportion of surgery alone and radiation alone, their prognosis is inferior compared to Group B, with a high proportion where combined modality, surgery and radiotherapy, was considered standard of care and standard of treatment in Jürgens sarcoma. So then the next question is, in patients with surgery, do you always need additional radiotherapy, or are there patients who do not need additional radiotherapy? When you look at the multivariate analysis, post-operative radiotherapy in patients with surgery has a significant impact on prognosis. But this, on the individual base, depends on size of the tumor, the complete surgical resection or marginal surgical resection, and age, etc., durability and long-term effect, etc., etc. So the message from this is the standard of care should be combined modality, and whether in combined modality a patient needs additional radiotherapy should be an issue of tumor board discussion, where these are discussed between the orthopedic surgeon, the radiation therapist, the radiologist, and the pediatric oncologist or medical oncologist, and so on. So tumor board discussion is absolutely essential in planning the appropriate therapy in an individual patient with Jürgens sarcoma. So you can think, what would you do in a patient with such an enormous pelvic Jürgens sarcoma? How would you treat it? We can go back to this in the discussion. So next, as we learned that the standard of care now is that 2 or 3 patients are cured, remain disease-free and can be considered cured, but still there's 1/3 of patients that present with relapse. So we have to discuss, do patients with Jürgens sarcoma have a second chance? What is the prognosis after relapse? So here you see that 73% of all relapses occur within the first 2 years after initial diagnosis. As rarely a patient relapses during therapy, so the second year after the initial diagnosis is a critical year. Then there is another 13% that have a relapse in the year after the 2 years in the third year. And 95% of all relapses occur within 5 years from prognosis. So only occasionally in Jürgens sarcoma there will be a late relapse. Nothing is not possible. Nothing is impossible in oncology, as you know. But the typical presentation is a relapse between the first 2 to 3 years following initial prognosis. And now let's look. Oh, sorry. Now let's look at the overall survival after relapse. So 1 year after relapse, 40% of patients are alive. 2 years after relapse, 20 patients are still alive. And 5 years after relapse, only 11% are alive. And 10 years, 9%. So patients with relapses have a very, very poor chance of prognosis. And let's look at this in somewhat more detail. Patients with local relapse have a poor prognosis, but fare somewhat better compared to patients with systemic metastasis or combined local and systemic metastasis. In patients with systemic metastasis, patients with lung recurrence do somewhat better compared to patients with bone metastasis and multi-system metastasis. And the only difference is patients with late recurrences, later than 2 years, have a better prognosis to patients with recurrent disease within the first 2 years following prognosis. So in summary, over 80% of relapses occur within the first 3 years. Systemic lung or bone relapses occur somewhat earlier, local relapses later. The prognosis after relapse is poor, with a 3-year overall survival of less than 20%. And factors influencing survival after relapse are relapse later than 2 years, with few patients with late relapses, local relapse, and lung metastasis compared to systemic disease, bone metastasis, and combined presentation. And so for patients with relapses, we urgently need new treatment concepts and new treatment modalities. So what can we do to improve this? This is now the dream section. Some groups are looking, do we have long-term consolidation therapy? Is there any benefit of maintenance chemotherapy? Because the second year after relapse is so dangerous and so typical for presentation. We looked at the impact of zoledronic acid, because in vitro experiments there was some synergism to chemotherapy, but the long-term result of this randomized study showed no benefit of the addition of zoledronic acid. Then the molecular oncologists are working on the Ewing sarcoma cells are expressing the IGF-1 receptor, and antibodies may have some impact. Can you stop the engine with preventing recovery after chemotherapy, or can you address the transcriptome, the translocation for treatment? So this is work in progress. I was involved in looking at the IGF-1 receptor antibody, and was very excited that we had approximately 20% response, but this did not result in cure, and the study where this was used up front, in addition to conventional chemotherapy, the phase 3 program showed no significant difference or no benefit of the addition of the IGF-1 receptor antibody. PARP1 is interfering with DNA repair after chemotherapy, and monotherapy had no effect, but this is quite plausible because you need chemotherapy destruction to interfere with the repair. And the phase 1 studies with addition of PARP1 inhibitors and second-line chemotherapy are ongoing. There was a good response, but long-term results are pending, so we don't know. There's Jeff Turetsky, an oncologist in the United States. He developed an agent that used the translocation as a target, and he's very excited. But this is a very, very early phase 1. There were some responses, and phase 2 studies are in the planning stage. And another idea that was born in our own group was as neuroblastoma, Ewing sarcoma cells express GD2, and this is a target for immunotherapy or even for CAR T cells. So this again is in planning stage, and whether this in the end will have an impact in improving prognosis of Ewing sarcoma has to be seen. So, 100 years later, what would James Ewing say? He would say, there's no cure with radiation alone. There is no cure with surgery alone. And important to note, there also is no cure with chemotherapy alone. Cure is possible, now possible, in 2 out of 3 patients, nearly 80% of patients with combined modality treatment, chemotherapy in combination with local therapy, and then the discussion is the appropriate local therapy surgery, radiation, or the combination of surgery and irradiation. What else would you say today? Intensive chemotherapy is essential. The preferred choice for local therapy should be combined modality with surgery and radiation. And what we need better ideas, new agents, new targets, and new modalities. So this is then the challenge for the next generation, for people who, as you said in the introduction, who were born when I became professor of pediatric oncology. This is the challenge for the next generation to develop these new ideas. This brings me to the end. We were good friends in the Ewing sarcoma world. And first of all, and above all, I want to mention Sir Alan Crafts, Professor of Pediatric Oncology at Newcastle University. And we tried hard to bring the major groups in Europe and outside Europe together. And you can imagine this is sometimes hard work. Thank you very much. Thank you for listening. And I will be willing to discuss any questions you have. Thank you very much.
Thank you, sir. Thank you for the beautiful presentation, very enlightening, highlighting a very difficult disease to treat as the Ewing sarcoma. Of course, you highlighted everything that's a disease of its systemic nature and the importance of using all we can in our armamentarium. I know we have been late on using the newer targets or how to incorporate the basic knowledge of science and how the disease occurs and evolves is now taking place. And I hope in the near future we'll have very promising data about all of this. If anyone who is listening wants to ask a question, Professor Jürgens is available. Well, let me start by myself. So, treating Ewing sarcoma for this long, I have a couple of patients that I had really very good, let me say, luck during treating them, because we put them on the Ewing protocol, which was a very intense chemotherapy using the 4 drugs and giving it for 5 days. Of course, you have noticed patients endure a lot of side effects because of the use of that intense regimen. And unluckily, some of the patients, they yet endure relapses when they're out from their treatment, even when with the consolidation. And using the timidal irinotecan, the salvage protocol, usually does not do, or even I had a couple of patients who responded for a couple of cycles and then they lost that, and I had to take them to transplant when they started response on other regimens like the gemcitabine or whatever that they'll respond to, and then we take them to transplant, and then after the transplant they're just complete response. So it is that crazy that the patients are running a lot of disease, they're having a lot of problems, and then they get exposed to the high dose chemotherapy with stem cell transplant, and then everything vanishes and the patients are out of it and they're good, they're disease free now 3 and 4 years
Oh,
out
that's
of,
wonderful.
yeah.
It's not very often that you can have a benefit of transplant in second remission. It's wonderful. Congratulations.
Yeah, so that's basically I know it has been put in test to promote the high dose chemotherapy even in the first line and use it as in consolidation, but I really can't figure out. But the high dose chemotherapy, using the high dose chemotherapy benefits a lot of the patients who are suffering with Ewing family of tumors.
Yeah.
So would you think, building on that if we developed some kind of a target and then using CAR T cells and promoting it to the first line would add on or would be of use for patients with the Ewing family?
Well, you see, this is, Khaled will tell you that the German queen of CAR T cells is Claudia Rössig, who followed me as Professor of Paediatric Oncology at Munster University. She is very keen. She's very keen to look into this. Okay. The problem is, which is the target that the CAR T cells have to hunt in Ewing cells. So she is very keen that probably GD2 could be a target that could be used in Ewing sarcoma treatment. So this is ongoing work.
Question, yeah.
So I couldn't say. It's an excellent idea in a patient who has a zero prognosis otherwise, but I couldn't discuss with you whether in the end this will be of any benefit. But it's a good idea, and I think it's a consequent and it's an important way to go.
Okay.
What was your conditioning regimen in your patients you transplanted? Was it busulfan-melphalan or?
Yeah, Bumel, just the Bumel.
Yeah. The only problem with Bumel is that you have to be careful when this patient has received radiation to the trunk.
Yeah.
And in previous trunk ear radiation, or in need for radiation to the trunk, either the pelvis or chest wall or whatsoever, we usually replace busulfan by treosulfan because there's less a problem of interaction between radiotherapy and VOD and whatsoever.
So basically, I use the PK directed busulfan.
Yeah.
So this is like this is where I was raised up at the MD Anderson with the professor. He's the guy who did the PK directed busulfan.
Mm-hmm.
So we don't see a lot of VODs when we're using busulfan. When you start using busulfan with the PK directed, when you did your homework for the pharmacokinetic directed busulfan dosing, and you do like the testing 1 week before you give the busulfan, usually you don't, because you already know the pharmacodynamics of in this body. So usually we don't run any problems with that, just very few. So with these two patients, we didn't have a problem or a significant problem with the VOD.
I see you're a transplant person.
I am. I was trained for.
Great.
So
May I ask one question? Professor Jürgens, you told us that the multimodality treatment, surgery, chemo, radiotherapy are the standard of care. But I want to know from you, are there any cases which should be treated without surgery? Can we exclude surgery in some regions, maybe to achieve a better outcome?
Well, you see, surgery, you're treating children, you're treating young adults, and given the presentation of Jürgens sarcoma, surgery can be very mutilating. And in a surgery, or when the surgery is associated with mutilation, you have to consider whether the benefit of surgery compared to sole irradiation is better than radiation alone. Also, surgery only makes sense when you have a complete remission of the disease following surgery. So in a patient where the surgery is intralesional from the presentation of the tumor, there's no benefit of intralesional surgery. You are better off with radiation in this patient. You have a better chance of controlling the disease. Also, in the poor patients that have a multifocal presentation of Jürgens sarcoma, let's say a pelvic tumor with metastasis to the vertebra, to other bones and lung metastasis, etc., 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 there is no benefit to expose this patient to a very mutilating surgical procedure. The only chance he has, because survival depends on control of all presentations. In that case, you do not do this patient any benefit when you go ahead and have a hemipelvectomy, and a year later, the patient is dying from metastasis in the spine and in the vertebra and in the ribs, etc., etc. So you always have to consider what are the consequences of surgery, what are you doing to the patient, and which is the local treatment modality with the best benefit for long-term survival and the least mutilation.
Thank you so much.
And of course, in young children, young children, as you know, from our day-to-day tumor boards, you always have to consider what are the late consequences of radiation in a growing child in an extremity compared to surgery. So this is an issue where you have to sit down in a tumor board again and again and again, and then come to a discussion and come to a decision between all disciplines and the family.
Yes, thank you so much, Professor Jürgens. I think if we don't have any questions, we can close our meeting today. Mohammed?
It was an honor to meet you, Professor Jürgens, and have you here. And we hope to see you soon in Egypt.
This would be lovely. This would be wonderful. Thank you very much for inviting me. It was a pleasure talking to you, and I hope to see you again.
Okay, that will happen. Take care.
Thank you. Bye-bye.
Bye-bye.
Cheers.
Cheers.